say is the main?
Some weak quads. The main thing that you want to do is it's an all-over sort of shotgun approach. You have to make sure she has that good glutes, maintain that good alignment. She has to have good balance, medial to lateral.
So it's just lower extremities, everything's got to be
good balance.
Right?
Yeah,
okay.
that's one of those that you try to make sure everything is as perfect as possible, and you already have like 2.5 strikes against you.
Right. Okay.
The patella baja is typically a post-surgical situation or a chronic situation with like patellar tendonitis, and it's just the opposite of the alta. Again, we have the length of the patella. Now this time the kneecap is shortened. So we oftentimes saw that when they were doing some of the ACLs where they were using the patellar tendon, and so you got a lot of scar tissue here. It really shortened up. So what would happen is it would lock the kneecap down into that groove, create significantly increased pressures in that kneecap, and have a real high tendency for pain in that area. In that case, flexibility work, stretching the quad, stretching the tendon itself is very, very important to work on. Tilt and rotation, like I just talked about, that's where it's very subtle, but taping can help. And then trochlear depth, we've already talked about the shape of that trochlea. Now, a biomechanical approach is a much more modern way of approaching it. The theory with that is rather than looking at the kneecap itself and how it's positioned, the kneecap is basically stuck in this whole extensor mechanism. It's just a part of it. It isn't separate. And so it's going to be influenced by all the musculature rather than it doing its own thing. And so by doing that, what you want to look at is exactly like we were just talking about. Flexibility, strength in all the components, your core, your hip strength, your hip hinge, balance of hamstrings to quad, balance of lateral to medial quads. So everything comes into play with the biomechanical approach, trying to maximize your alignment. And one of the theories that's typical with a knee problem is where they don't decelerate very well, or their ability to absorb shock. What's going to happen is the pelvis is going to collapse forward, get a forward roll. They're going to arch their back. They're going to drop their leg in. They're going to externally rotate their tibia, and they're going to pronate at their foot. So what's happening is this knee is driving in. The kneecap wants to stay in between the foot and the ankle, and so it's just getting yanked out of place, putting a lot of stress on the medial structures significantly. The lateral structures will get very tight, so at some point they're going to get painful as well. So lateral pain, medial pain, and even inferior pain are very, very common sites of complaints with kneecap issues.
Wait, medial meniscus is the one that gets torn the most, right? Versus lateral.
Medial is most common.
You have no medial meniscus, right? Or you have like
medial meniscus is most common, and one of the reasons.
Most common, but I've had medial and lateral, mostly lateral.
Yeah, lateral is not the best one to really tear. Medial is more common, that terrible triad that they talk about, where the ACL goes, the meniscus goes because it's such an angulation in the knee, and then you tear the medial collateral ligament. But the medial meniscus has an attachment with that medial collateral ligament. So when that ligament is stressed, it just yanks that cartilage, and it's very common. It tends to be a little more restricted, and that's why it's easier to catch. A few of the tests we do for flexibility, I actually mentioned this to Trevor yesterday with regard to one of his patients. The Ober's test, we're looking at the flexibility of this area. But what you're really looking at is the ability for that leg to drop down, and then how it influences what kind of discomfort you're putting or creating in the kneecap when you tension those structures. So we have them in side lying, we extend their hip, drop their leg down. It should almost drop all the way to the table. A lot of people don't. And then by sort of flexing and extending their knee, you can really elicit a lot of their complaints that they have. Typically at about 20 degrees of extension right there, is the IT band is on maximum tension, and that's where it's going to create a lot of their pain.